Good evening. I'm Milind Sovani, one of the respiratory physicians and sleep physician from Nottingham, UK. Um, I would like to welcome you all to what should be a really exciting session where we will discuss all things about circadian rhythm. And we have got the honor today to have our speaker, Dr. David Cunnington. He's a renowned sleep physician. He is based at Sunshine Coast University Hospital. He has spent a lifetime studying sleep medicine, doing research, treating patients, and importantly, he's also a co-founder of Sleep Hub. He has been a close associate and a mentor for SEAASM, including the SAR study that is currently going through peer review process. So it's really good to have David today doing the talk. And as panelist, we have Dr. Kashmira Jhala, who is head of Department of Pulmonology at Apollo Hospitals. Thank you again, Dr. Jhala, for sparing your time and joining us as panelist. And we have got another eminent pulmonologist in Dr. Arora, who is from Gurgaon. Again, both our panelists have extensive experience in pulmonology and sleep medicine. So without further ado, I will request David to start his talk so that we can maximize the time we have for learning. David, over to you.
Yeah, thank you very much, Milind. So I'm going to talk about the circadian rhythm and give you an outline of some of the physiology of the circadian rhythm, talk about how I think about circadian rhythm disorders in a clinical sense, and hopefully that's going to set the scene for some discussions with our panelists. And by all means, put questions in the chat box as we go along, because we hope to get to them and be able to discuss cases later on in the session. Now, I really like this quote. So Elvis Presley, you may know, is a very famous Western sort of rock star. But one of his songs was, it said, rhythm is something you either have or you don't have. But when you have it all over. Because we thought about the circadian rhythm as really being just this master clock in the suprachiasmatic nucleus. But it turns out that every single cell in our body has its own clock. And within organs, each organ has its own sort of timing and clock. And so we're basically a system of clocks, and how well those clocks synchronize from a cellular level to an organ level to a system level to a whole body level really is a very strong determinant of health. And we'll talk a bit more about that, I'm sure, in the discussion. So when we think about the circadian rhythm, like all biological rhythms or all mathematical rhythms, it's got a number of properties that we use when we're trying to describe the circadian rhythm. So it has a period, so that is the length from the start of one cycle to the start of the next cycle. Now, we live on a planet that has a 24-hour cycle, but the median period for humans of the circadian rhythm is a little longer than that. It's about 24.2 hours, so about 24 hours, 12 to 15 minutes. And so if someone is withdrawn from all external stimuli, they will actually sleep a little later every single day. But it's just that resetting of the circadian rhythm by light and by activity that means that we are able to often get up the same time each day, sleep at roughly the same time each day. Another property of the circadian rhythm is the phase, and that's the relationship of the rhythm to the outside world. So what we want, or a very common pattern, is if you look at the red line and think of that as core body temperature, the core body temperature is at its lowest in the dawn time and then starts to tick up just before we start to wake up, and then body temperature gradually increases as the day goes by. And we go to sleep just as we've reached our peak core body temperature and that starts to drop off. That's actually one of the physiological triggers for sleep. So the phase is very important when we think about clinical sleep disorders. And then I haven't got it on this slide, but the amplitude, or think of that as the difference between the peaks and the troughs of the rhythm, is the third important property of the circadian rhythm. If you think of it at a cellular level, the amplitude really reflects a concentration of neurotransmitters being excreted at the same time. So it's how many cells in that suprachiasmatic nucleus or in these body systems are in sync and firing at the same time gives you that amplitude. So it is a bit of a measure of entrainment. Another concept I find really helpful in clinical practice is thinking of the patient before you and the different clock systems that are involved in their life. So all of us have a social schedule. What time we need to get up, what time we need to get the children managed, what time we need to get out the door, when do we need to be at work, what other commitments do we have. We also live in this planet or live in this world that has a light dark or a sun cycle. And the third clock that we're all beholden to is our internal body clock. Now, again, these things aren't always in sync, but our health will be at best when both our social schedule, the light-dark cycle outside of the planet that we live on, and our internal body clock are all in sync. But it's not that simple, because in this day and age with artificial light, we're using light sources to distort that sort of sun or external signal. So we have the outside sunlight, but then we have our own indoor light that can actually distort where these other clocks sit. And then if we co-sleep with a partner, there's yet another clock. There's really nice data about co-sleeping partners. If you've got a late night type and an early morning type, over a period of time, their clocks start to come a little bit closer together. So the late night type comes a bit earlier, the early night type comes a bit later. So there is an entrainment with sharing a bed or co-sleeping with a partner. And sleep, when you do co-sleep with a partner or other family members, sleep's a shared experience. And so if someone's on a different clock to yourself, it does interfere with your sleep. But there's lots of different clocks that we're all beholden to or enslaved to. And when you're seeing someone in clinical practice, it's helpful to think about these different clocks. I saw a patient in the clinic earlier today whose father works night shift, whose mother works early morning shifts, and they themselves are at school, so in a day shift. And so within the household, there's these three different social schedules that are all somewhat removed from the sun or the day-night schedule. And not surprisingly, everyone in the house wasn't sleeping particularly well because there's a desynchrony between all of these clocks. Now, when we come to the clinic and think about the clinical tools that we've got for measuring the circadian rhythm, it's tricky because it's not something we can see. It's not tangible that we can put our finger on. So it is often pattern recognition, collecting data over time to look at these patterns and changes. And the more data that we've got, the more we can then estimate some of the measures that we use to look at the circadian rhythm, like the phase, the relationship to the outside world, the sleep timing, sleep duration, whether there's a variation between weekdays and weekends, and also whether there's impact from medications. So simple visual sleep diaries can be quite helpful in this regard. So this is an example of the type of visual sleep diary that I find quite helpful. There's 2 weeks of data in the rows down the page, and across the columns there's one box for each hour of the 24-hour day, with people shading in when they're asleep and marking when they're in and out of bed each night. And so you get a nice visual pattern of things. I find this type of diary much more helpful than the diaries where people might write descriptions or annotate how much time they've been asleep, because these are very visual. And in a circadian rhythm sense, it's the visual pattern recognition that's really important. Another example of a sleep diary, this is a 17-year-old that I saw yesterday who's got ADHD, autism spectrum disorder, obsessive compulsive disorder, and complex PTSD. There are lots of reasons to have very marked hyperarousal. His parents are separated. He lives with his mother who works full-time. And so he's at home by himself all day. And so with that disordered mental health that's causing hyperarousal, no one to give him a regular social schedule, It's no surprise he's got this type of sleep pattern, which is very characteristic of irregular sleep-wake rhythm disorder or a low amplitude circadian rhythm. Once you move beyond paper diaries, this is an Excel spreadsheet that a patient of mine had plotted. This is over about 8 months of their sleep timing. And this is a very typical pattern of non-24-hour sleep-wake rhythm disorder, just showing that gradual drift of sleeping a little bit later each day. This particular person's got quite a long circadian period, or tau, so they've got a 25-hour and 20-minute tau, and so have been a lifelong person with delayed sleep phase, but now has had some problems with hyperarousal anxiety, trauma, that's just pushed them into this non-24-hour sleep-wake pattern. Now, as well as visual sleep diaries, once you then graduate to, say, someone's putting something in an Excel spreadsheet, or if people have wearables, in this day and age, we can now look at using that data and using large language models or other models to do calculations on that data to gain more insights. Wearables such as the smartwatches, you can actually now export data, pull them into some of these AI models and use tools like Python or MATLAB or other coding tools to run a whole range of different analyses on these data to gain clinical insights. This is an example of a patient of mine who had around 2 years of data in their Excel spreadsheet, and I was able to look at total sleep time distribution, which is the graph on the left, to look at the sleep length, get a histogram plot of the sleep length. The right-hand graph, one's a raster plot, which enables me to look at that non-24-hour pattern and the gradual delay. And then the graph on the far right is calculating the sleep regularity index. So there's increasing research to show that the regularity of sleep is probably more important than sleep duration in terms of long-term health prediction. And so an irregular sleep pattern, which is usually a sleep regularity index of less than 80, is correlated with worse mental health and physical health outcomes in the longer term. And although this person's got non-24-hour sleep-wake rhythm disorder, their sleep regularity index is actually not too bad because they have quite a predictable pattern. They're letting themselves free run with a circadian period of about 25 hours and 20 minutes. When we then think of the clinical sleep disorders as they're defined in the International Classification of Sleep Disorders, there's delayed sleep-wake phase disorder, and that's where the sleep timing is more along the lines of the blue graph rather than along the lines of the red graph. And that's where the phase is offset or delayed compared to the external world. There's a normal period, there's a normal amplitude, there's just this phase delay. Now, having said the period's normal, to be able to phase delay, you've got to have a longer tau or a longer circadian period. So although the median, I said for humans, is about 24 hours, 24.2 hours, people who are early morning types are a bit shorter than that. People that are delayed sleep phase types tend to be a bit longer than that. So they do tend to have a little bit longer circadian period. That can also happen at phases of life, such as during adolescence. And the typical clinical presentation is people might go to bed at their desired or anticipated sleep time, 10 p.m., for example, but may not actually then sleep for some hours after that. And then when they want to get up, say at 7 a.m., they might not be able to arise for some hours after that until, say, 10 a.m. And even then might feel heavy-headed, tired throughout the day and take a while to get going. Now, the opposite to delayed sleep phase is advanced sleep-wake phase disorder, and that's where people are going to sleep earlier than they would necessarily like to, but in particular, awakening earlier than they would like to. This is very common in older age, particularly in Western countries, where often with older age, people are going to bed quite early because they feel like, okay, my day's done, there's nothing really much I need to be doing in the evening, but then find themselves waking at 3 or 4 in the morning and then getting frustrated because they're trying to go back to sleep, but in essence, their sleep period has finished. They've exhausted all their sleep drive. Another disorder that I've already talked a little bit about is irregular sleep-wake rhythm disorder, which is really characterised by reduced amplitude of the circadian rhythm. If you think of the circadian rhythm as driving that alertness signal during the day and the sleepiness signal at night, if the amplitude is lower, then during the day you're not as alert and during the night you're not as sleepy. So the probability of being awake or asleep at any time in the 24-hour cycle becomes much more of a 50-50 probability rather than a higher probability of being awake in the day and a higher probability of being asleep at night. And this is very common when people have physical or mental health issues. The people with chronic illness often have this irregular sleep-wake rhythm disorder. I'm seeing it very commonly in Australia at the moment, seeing a lot of people with neurodiversity, such as ADHD, autism spectrum disorder, developmental disorders, where this is very common. And I've already shown you one sleep diary of irregular sleep-wake rhythm disorder. This is another sleep diary of someone with irregular sleep-wake rhythm disorder. This was someone with severe PTSD who had really high levels of hyperarousal and it's got this very unpredictable, chaotic sleep pattern that doesn't have any rhythm to it. That's that probability of being awake or asleep at any point in the 24-hour cycle being 50-50, rather than higher probability when it's dark, lower probability of being asleep when it's light. Another one of the circadian rhythm disorders is non-24-hour sleep-wake rhythm disorder. This is one of those visual diaries that someone filled in on their computer, showing that drift or the progressive becoming later and later each day of that pattern. And you can see you need at least a couple of weeks of data to be able to see this pattern. And the more data, the better. This is part of an Excel spreadsheet of another patient of mine who's kept 5 years of data, which has been fantastic in terms of doing data exploration and calculating a whole range of different things about his sleep. But he's got a very typical non-24-hour sleep-wake rhythm disorder. And then on the right-hand graph is when we started to introduce some strategies to help entrain his circadian rhythm. And we've been able to hold his circadian rhythm now for about 12 months. He hadn't been able to work for about 10 years in this non-24-hour sleep-wake rhythm pattern. It wasn't easy to get his circadian rhythm on track. This wasn't as simple as just give him some light in the morning and block some light at night and use some melatonin. It's quite complex. This particular individual does have autism spectrum disorder, and so we're treating with clonidine at night, some SSRIs as well to reduce arousal, some melatonin, morning light, and some dexamphetamine in the morning as well. So complex sort of regime, but it's actually been very effective at entraining his circadian rhythm. Now, what about the tools that we can use to entrain the circadian rhythm? So the term that's used for this is Zeitgebers, which is German for time givers, and they're environmental cues that synchronise the internal clock to the external world. And without Zeitgebers, people will free run. And they were those typical experiments done by a range of early sleep researchers in the sort of 40s and 50s, where they went into caves and had no external light for weeks and months at a time and plotted their sleep timing to show that they gradually phase delayed or were in a non-24-hour sleep-wake pattern. Now, the most important of the Zeitgebers is light. Now, light feeds into non-visual cells in the back of the eye, which then feed into the suprachiasmatic nucleus and suppress melatonin production. And so in the particular wavelength of light that the non-visual cells in the eye are sensitive to, are the sort of 480 nanometers of light, which is the cold sort of colour temperatures, greeny blue, the colour temperatures, which are often seen in morning light. They're not so much sort of the dusk light, which is a more orangey, red, warm sort of colours, but colder sort of colours. And those colours are often overrepresented in screens, which is why sort of screens in the evening are an issue. And some of this work demonstrates the issues with artificial lighting, such as electrical lighting. The bar on the top shows that in the presence of electrical lighting in winter, melatonin onset is delayed. And so that's the light suppressing melatonin secretion, delaying the onset of melatonin secretion, which is really important in achieving sleep onset. Whereas the bottom graph, in natural winter light, you get a much earlier beginning of or onset of the increase in melatonin and peak in melatonin concentration, which then allows sleep onset to be earlier. And so modern lighting environments can really delay both melatonin production, but also sleep. The other Zeitgebers beyond light are movement, and particularly large joints. So that's sort of getting up, being vertical, having people walking, stretching, those sort of movements can be really important to cue in the circadian rhythm. Feeding, so meals can also sync the circadian rhythm. Remember, I talked about every single cell in the body has its own clock. So you want your gastrointestinal system, your cardiovascular system from being upright, your musculoskeletal system from moving, your neurological system from being awake and alert and mentally engaged. You want all of these systems to be getting these Zeitgebers or external cues and time signals that, hey, this is the time the day starts, to be able to start to entrain the circadian rhythm. I'm just going to talk through a couple of cases and then we'll be able to break to the panel and answer some questions. So the first example to talk through is a 15-year-old school student, Sally, trouble getting to sleep, going to bed at 10 p.m. because her parents want her to be in bed at that time to be able to get up for school the next day, but not able to get to sleep until 1 o'clock, 3 o'clock in the morning. Has an alarm set for 6:45 on school days, but on the weekends when she's allowed to sleep in, will sleep spontaneously through till around 10 a.m. And typically has been tired in class throughout the morning. In the right-hand panel, you can see a sleep diary. You can see from this why I don't like these sleep diaries and find them far less helpful than the visual sleep diaries, which really make it much clearer what's going on. It's a lot harder to digest this type of diary. But phase delay, so in bed at a certain time, but not going to sleep for some time after that. Now, we put in place a strategy that's outlined on the left, and then her sleep diary is on the right. Essentially, we chose a 12-hour window starting from her approximate spontaneous arising time, which is 10 a.m., because that is the time when biologically the system is looking for the light signal to then respond to that and then train to that. If I just got her up at 7 a.m. and said, look, you just need to get up at 7 a.m. every single day, it's still in the part of her sleep cycle where the body's not looking for light as a synchronizing signal because the body thinks it's still middle of the night. And you can actually just perpetuate phase delay. So you've got to start with working out where's somebody's spontaneous awakening time, because that's the time their system's going to be receptive to light. So we had her getting up at 10, light exposure for 30 minutes. And then in terms of the melatonin instructions, we worked back 12 hours to be taking the melatonin around 12 hours before the light exposure. And then the time of going to bed was around 8 hours before the sort of time of getting up and light exposure. So that was the instruction. So melatonin 10:30 p.m., then bed at 2:30, up at 10 and light between 10 and 10:30. And once there's that entraining sort of pattern to get control and entrain the circadian rhythm, then there was the gradually shifting it earlier over time. And you could see visually from the graph there how we were able to slowly shift her timing over a couple of weeks. Still not as early as she wanted it to be. So after about 2 weeks, we were at midnight till 8 a.m. But she was still wanting it to be earlier, but we can still keep following that progressive advancing of the circadian phase over time. Now, that's what we wish all our circadian cases are like. Pretty straightforward, put in place pretty simple circadian principles and Zeitgebers, both of an evening and of a morning, to then entrain and either advance or delay, shift the rhythm the way we want it to shift. But unfortunately, in clinical practice, things are never that straightforward, really. Patients are much more complex these days that we're seeing. So Cameron's another case, a 30-year-old who's living at home with his mother, significant comorbidities and mental health issues of depression, autism, ADHD, and on medications including lisdexamfetamine at a fairly high dose, citalopram also at a fairly high dose, quetiapine and melatonin also at a high dose. And despite all of this, sleep still very irregular, often not going to bed till 2 or 3 in the morning, which is hard for his mum as a carer, sleeping until early afternoon, tired throughout the day and spending most of his day in his room. So in terms of trying to manage someone like this, yes, we'll still use those entraining stimuli, so light in the morning, reducing light at night, and using melatonin at night to try and advance circadian phase. And you only need a low dose for that. So some people say 0.3 milligrams, but not more than 1 milligram is needed to entrain the circadian rhythm. But for someone like this, we also need other behavioural strategies. So when there's that sort of autism, ADHD, anxiety, depression, there are problems with self-regulating behaviour. But it really is a case of putting in place some external social schedule so that someone to be helping self-regulate, turning off things in the evening, getting prepared for bed, getting up at a certain time in the morning, actually putting in place these strategies. And often the medications can perpetuate a lot of the issue. In this case, the quetiapine, Seroquel, was being used to try and, by the psychiatry team, to try and force him to sleep. But in fact, it was just overly sedating him. It wasn't necessarily putting him to sleep, but when he did finally sleep, it was just adding to that phase delay because he couldn't wake up and was heavy-headed in the morning. So we switched that out to agomelatine, anti-anxiety, antidepressant medication that has some melatonergic properties and works via serotonin to try and get a little bit of sleep effect of an evening, but importantly, a bit more anxiety effect without the sedation. Okay, so that's really what I wanted to cover. So the key messages I hope to have conveyed is that it's not just about the circadian rhythm and the central clock. Think of that Elvis Presley quote, we've got to have rhythm all over and really think about the circadian rhythm as a whole body problem. Light is the most powerful tool we have to entrain the circadian rhythm. In clinical practice, when we're collecting data in this area, patterns trump snapshots. So really try and collect as much data as you can over a long period of time. And even though visual sleep diaries are very simple, they're actually really powerful to be able to assist. But if someone has a wearable, getting them to wear that and then downloading or exporting the data and doing mathematical analysis on that in this day and age can be really helpful too. When you're assessing people clinically, think about the multiple clocks that are part of their day-to-day life and that they're enslaved to, and consider all the inputs or all the factors that are going on to their physiology. And this is where the anxiety, trauma, other things come in, because they're often factors when people have intractable circadian rhythm problems and you're doing all the circadian rhythm stuff and it doesn't shift. You've got to think, okay, there's something else here. And often hyperarousal for me is there something else? So I'll leave you with that and thank you. And this is my morning in training signal at Watala Beach on the Sunshine Coast so that I'm not too phase delayed. Thank you.
That was really good, David, and jealous of the last photo that you put up there. Um, right. So I'm sure, there is a lot to sort of learn from that and then think about and talk about. But I would ask Dr. Jhala if I think she has got a couple of really good questions. So if she could start off the discussion with her questions, please.
Okay, so thank you very much for a very great and very crisp presentation, Dr. David, and thank you very much, CSM, for having me in this platform. If you're talking about the circadian rhythm disorder, which are the most common, but if I am telling you in Indian setup, uh, we have a very good awareness now if we are talking about sleep disorder, breathing, OSA and all. But if we are talking about circadian rhythm disorder, then definitely in our Indian setup, still it is not that much addressed, number one. And if we are talking about the what are the common or which circadian rhythm disorder are common, the I would say each and every what Dr. David has described, whether it is a delayed sleep wake disorder or advanced or non 24 hour disorder or sleep shift worker disorder, all are very under recognized or under diagnosed. That is maybe because of the most important thing is a physiological misalignment and the clinical presentation, which also again misleading with the clinical presentation of insomnia or poor sleep habit or poor sleep hygiene. Because if we are talking about delayed sleep phase wake syndrome, then it is more common in adolescent. And again, because of that poor sleep habit and screen time and physiological delay, because of screen time it is more delaying, and they have to go to school, so they have to wake up, and so they have a very poor sleep and very fragmented or very less sleep time, would say. uh, uh, if we are talking about advanced sleep syndrome, then it is more common in elder age group, as we know. And again, because of their retired lifestyle or less working hours, or maybe because of we have a wrong myth, because of aging they have a very less sleep, and because of they sleep early, and because of that they wake up a little bit early, and so they have presentation of insomnia or sometimes depression and all these things. Even again, if we are talking about sleep wake shift worker duty, then it is occupational hazard, and people do have a irregular sleep habit and all these things, again it is under recognized. So circadian rhythm sleep disorder are very common but really very underdiagnosed because of all this poor sleep hygiene habit and co-incidence or clinical co-symptoms with insomnia and all those things.
Thank you. Thank you. So I think, David, the question is how easy or how would you differentiate? You've got a young person coming to you. How would you differentiate somebody with just poor sleep hygiene or insomnia as opposed to circadian rhythm or disorder? How would you
Yeah.
go about it, please?
Yeah, and often they've got a bit of each. So it's really, what clinical practice is like. It's rare that they have just the one thing. They have a little bit of all these things. And so what I generally find is up front, appointment number one, I can't pick these things apart. It might be a stronger flavour of one or the other. And so I'm going to start working on what's the strongest piece. And sometimes it's family or the patient themselves might say, "Well, this is just a clock problem. We just need to sort the clock out." And so I'll go, "Okay, well, we'll do the clock measures." And when they fail, then they might engage in, "Hey, there's some anxiety or there's some other factors that we need to address here." So yeah, it's not easy. And it's not something we just solve, bang, that very first time. What I'd love is a bedside test. I could just do some biomarker to be able to pick that biological circadian nadir at the bedside. We don't have that at the moment.
There is an interesting question from Dr. Ghulam Hassan from the audience. So he's asking, can food allergies distort circadian rhythm and lead to food allergy insomnia?
Sort of. So the way I'd sort of think about that is there's, food is one of the entraining signals, right? So food at the wrong time can distort the circadian rhythm. But then we also know for other disorders. So let's say there's some of the other immune-mediated disorders like mast cell activation syndrome. So there's different foods that can trigger this immunological inflammatory response that then causes sympathetic nervous system activation that's then going to delay sleep onset. And that could be via an allergy type of mechanism. So yes, can happen. It's not a common presentation, but yeah, absolutely.
Oh, thank you. And I think we have got another interesting question from actually Dr. Narayan Swami from Tamil Nadu. And they ask whether N3 stage of sleep is that decreased with delayed sleep phase, or sleep is delayed. I suppose delayed sleep will reduce that, but is there a difference I'm paraphrasing their question now. Somebody who usually has got normal circadian rhythm sleeping late, as opposed to somebody with delayed circadian rhythm sleeping at 3 a.m., is there a difference in the deep stage that these two individuals experience?
No, generally. So yes, if their sleep's truncated, so they're delayed and you have to get them up early. But no, that's really part of the definition of delayed sleep phase. The sleep itself is relatively normal, but the phase is shifted compared to a normal phase.
And somebody with normal sleep phase, if they sleep late, they presumably would have some impairment of sleep architecture and suboptimal sleep quality.
Yeah, right. So that's going to be me tonight. So for my 7 a.m. clinic, 7 a.m. clinic that's starting tomorrow, I'll be a bit short on N3 sleep for tomorrow. So that's okay.
I really appreciate your input, particularly on circadian rhythm when you're staying up late, David. Thank you.
And I think, if I may add, that if a person is chronically sleep deprived, as against just a sleep phase disorder, then overall his restorative sleep will go down with time. So maybe it's a chronic accumulation of that rather than a one-time event.
Thank you. That's really, again, a good point. And I think talking about exposure to light, I think we have got a good question from Dr. Palanivel from Tamil Nadu. So they are asking that traveling back from work at night, say around 9:30, as you travel, you get exposure to bright light, road light. What impact would that have on your circadian rhythm?
Yeah, so it's going to have negative effects, but it's not just the light, right? So what's preceded that, right? So if you're coming home at 9:30 p.m. and been working to that time, you've been upright, you've been cognitively engaged, you may well be not yet had your evening meal. And so the light might be one factor, but there's many other factors that are going to be negative aspects to the circadian rhythm. Because, the ideal thing would be by the time it's dark outside, we're all tucked up in our homes in a nice light-controlled environment. And that's pretty challenging in this day and age, unless you work an 8-hour day and, life's pretty cruisy.
And I think there are good data these days that over last sort of 80 years or so, as light pollution has increased, the quantity of sleep as a population we are all getting has gone down somewhat compared to 100 years ago, where the light pollution was not as much. And I suspect there are some data around, I think, around effect of night pollution on birds' behavior as well, as in, so
there's a really nice big study, the Nurses' Health Study, 70,000 nurses, and looking at the effect of night shift. And that's where it's been found that shift working at night over many years increased the risk of solid tumour cancers, breast cancer, colon cancer in those nurses.
No. Thank you. I think what we will do is we will take more questions around diagnosis, but we also want to look at you know, the practicalities of treating circadian rhythm, and not just treating circadian rhythm per se, but how circadian rhythm affects treatment of various other conditions as well. I would like to invite Dr. Arora to quiz Dr. Cunnington on those topics, please.
Thank you. So, I think, like Dr. David has pointed out, there's so much of irregularity in presentation of these disorders that often it's difficult to distinguish between them. And since research is still upcoming, Dr. David, what I feel is just like we've started phenotyping everything before giving the right treatment. Would it really matter if we, start distinguishing clinically in our routine practice between the prototype, the endotype of whether somebody is a night owl and see whether it would change the way we manage various diseases around it? Would there be any clinical implication in now starting giving personalized medicine based on how your chronotype is also?
Yeah, and absolutely. So, and this is where the basic science research is well ahead of clinical practice. There's very good basic science data showing that timing of chemotherapy drugs, timing of a whole range of different medications should bring into or chronotherapy or chronobiology should be part of that consideration to get better outcomes. Now, do we do that in clinical practice? Absolutely not. We're totally blind to that. But absolutely, if we had a good bedside test of somebody's circadian rhythm, and then, for example, you're trying to treat their tumour and you want maximum kill rate from your chemotherapy agent with their tumour, we should be able to, if we have good biomarkers for their circadian rhythm, predict the timing of giving the drug to get the maximum kill rate and the lowest toxicity out of those drugs. So yeah, for me, if I was thinking of, retraining, if I was starting my career, I'd be wanting to be a chronotherapy clinician, because I think you could then be across all the areas of medicine and teaching all areas of medicine how to get better outcomes across everything they do.
Yeah. And so much so in our context, even with our asthmatics, we've seen that, a lot of them have nighttime symptoms. So, for patients who are on once a day therapy, I would rather give them a night dose of the once daily inhaler rather than giving them in the morning, because I know that that will be a nocturnal increase in airway resistance and that would work. So I think, right, like just like we ask patients about various other symptoms, it's good to ask them about their sleep as well and kind of determine the phenotype we're dealing with, at least clinically, till we have biomarkers, like you said, at our bedside. Another thing regarding treatment, Dr. David, is that often we get patients where we know that this patient needs an adjustment with his sleep cycle, and we are often confronted with the issue of just whether giving him light therapy or now adding melatonin as well, because the potential of misusing the drug, overusing it, because in India it's available over the counter, you don't need a prescription, and then we have gummies in general stores also giving melatonin. So I've had a lot of teenagers and young patients especially who are already eating melatonin gummies by the time they come to me. So where do we strike that balance? Should we go ahead and tell them that we'll do the light therapy first and try to wait, or we do both together? Because we often end up doing both. But what was your take on it, and what should be the ideal way to go ahead with it?
Yeah, I do like having melatonin as part of the package. But you're right, if someone can buy it in the store, it loses some of its mystique or some sort of standard tone. we're going to make it up. It's a bit of the magic of sort of trying to make it as something that's going to be more effective and more therapeutic for them, so that it's not just, oh, I've already done that gummy thing. Because in reality, when we're trying to clock shift, it's generally rapid acting melatonin, low dose, 0.3, 0.5 milligrams, which is often not a formulation people have been using because they've been trying to sedate themselves with melatonin, 5 milligram gummies, and eating 2 or 3 of them to try and force themselves to go to sleep.
Yeah, and I think the message that needs to go across is also in the right way of using it, because even amongst practitioners, we see that there's too much of variation. If Dr. Milind allows, then maybe we can discuss a little about it, because I'm sure a lot of audience will have questions pertaining to how to time it and the ideal dose to take it.
What points you made, Doctor, are absolutely very pertinent. That, such as considering timing of even the inhalers that we give, and like David said, looking at chronobiology. Excuse me. Sorry. But I think, as you again pointed out, we have also got a couple of very good questions. So I think Dr. Modi is asking what preparations do you have in small doses, and as David had just said, you are looking for short-acting preparations, David. And the other question is, would somebody who is taking these melatonin gummies, would they actually suppress the endogenous melatonin production? What impact?
So there's no evidence that happens. I know there was some talk some years ago that, particularly in older adults, we didn't want to be using melatonin, but there's absolutely no evidence that it does suppress endogenous melatonin. And the timing's tricky. So, melatonin can be used for different things. It can be used as a sedative hypnotic. So there's, nice Israeli data looking at long-acting 2 milligram formulation of melatonin taken an hour before bed in adults over the age of 55 for insomnia. But it can be used as a chronobiotic, and that's much more 0.3 milligrams. Think of it as a darkness signal. So you're wanting it around the sort of time of dusk to be giving that sort of, okay, light is fading, less suppression of melatonin, I'm going to augment that sort of melatonin level. And so that can be 4 or 5 hours before someone's actually planning to go to bed. So when you think about timing, it's not what time do I give melatonin, it's what is the purpose I'm using melatonin for? And that's going to determine both dose and timing.
Thanks, David. In terms of, when people are sort of a shift work syndrome, do you actually do any blood test to measure their melatonin? People who are struggling with shift work syndrome, or is that more a research tool?
Yeah, it is a research tool, and it's really problematic because even minuscule amounts of light and activity can suppress and impact melatonin. So we've looked at this even in a research paradigm, and we've bring people into the hospital in the middle of the day, lock them in a dark room with only 10 lux of light, have to lay in the bed doing absolutely nothing to be able to then reliably have melatonin that's not distorted. Now, in the real world, no one's ever going to do that, because they're going to be distracted on their phones, have light exposure, they're up and moving around. So measuring melatonin in that setting is, completely useless. And shift work's really challenging because it gets classified as a circadian rhythm disorder, but it's really a social clock disorder rather than a biological disorder. And you're trying to put a square peg in a round hole. So you're trying to mitigate the harms from shift work. That's often what we're trying to do, rather than trying to shift someone's circadian rhythm to be compatible with shift work, because we can't shift it that quickly. People are working night shift and then got day responsibilities. And so, it's more a harm mitigation. So, I'm doing blood tests in people with shift work, but I'm doing their metabolic profile, their cardiovascular profile, because they just have poorer health because of that misalignment of the sort of circadian rhythm with their social schedule.
And do you prescribe? Sorry, I think Dr. Jhala wants to ask something.
Regarding this, I just wanted to ask Dr. David, if you're talking about shift worker duties, as you say, or also there are evidence they are more prone with cardiovascular risk and morbidity. So, is there any particular biomarker or anything which we should advise? Because I see a lot of patients like this, and mainly pilot, which they are coming to us. So, is there any specific advice from your side? According to your experience, we can advise them or regular, because they don't come for regular follow-up, but still we can just give them advice regarding their sleep hygiene, or what can more tell them about to prevent their cardiovascular risk or something like that, for take-home message for specifically shift worker.
Yeah, I think it's very general advice, but I think one thing that shift workers don't understand is just working shifts greatly increases cardiovascular risk and greatly increases long-term health risk. And so really for shift workers, I'm really trying to tell them, make sure you're taking healthy meals, you've got good food choices, on your days off, you're actually getting adequate rest, self-care, exercise, connectedness with family, for sort of mental health reasons, because you're at a much higher risk than the general population for both mental health and physical health disorders. And so sometimes they think it's just the sleep. As long as they get enough minutes of sleep, life will be fine. In fact, it's not. They've got to have all these other proactive health strategies to manage these other health risks associated with shift work.
So can I add? So,
Sure.
so another thing that Dr. David, we've seen is that again in shift work there are varying kind of shift work patterns. There are some who always work the night shift, so they kind of adjust to that. So one of my patients would just wear dark glasses on his cab back home, and when he's back home, the curtains were already drawn, and he would create that environment for sleep and go to bed and wake up fresh. While, like for others like us, like doctors and nurses, we have a morning, evening, night shift kind of a pattern. So thrice a week we are on mornings, thrice a week nights. So when such a patient comes to us whose shift work is changing very frequently, we're often boggled by how to help them, because the pattern is not uniform. Today they are going to get good morning hours, and then so what kind of a strategy can we apply to such patients who have very, very variable shift pattern as well?
Yeah, right. So again, I'm pretty honest with them, and I'll tell them that the shifts are non-biological. There's no biological way to match your circadian rhythm to this. If they're not having to do overnight, so maybe doing mornings and lates, which is a common nursing shift pattern, we use anchor hours. So we'll pick, maybe a 5-hour block, midnight till 5 a.m. No matter what shift they're on, they can sleep those hours. And then they'll have swing hours, so 1 or 2 hours that they'll either have at the start or at the end that shift depending on whether they're on a late early. So there's at least that fairly consistent anchor block of sleep. So that's sort of one strategy for that rapidly rotating shifts. Another is, when people know it's non-biological, I get them to take a very opportunistic approach to sleep. Have the opportunity, take it. You're going to be sleep deprived. Thinking in a much more fluid way about sleep rather than, I've got to get my sleep all in one block and it has to be sort of meet some sort of social norms.
Yeah, I've heard Emirates crew gets cubicles in the first class suites section where by turns they are mandatorily asked to sleep during long overnight haul flights to maintain that.
Yeah, and some can and some can't. So that's what we see with the flight crew. The other thing that's fair to say is there's a genetic basis to it. So some people have a very strong circadian rhythm, so their sleep's very strongly clock-driven. They don't do well with shift work at all, and they're often the individuals that do it for a year or two and just go, I couldn't do it, and move on to something else. Others have a much more weakly mediated circadian sleep regulation, And they're the ones who do night shift, do day shift, sleep. It doesn't seem to bother them. They change shifts and they do pretty well. So that's another thing I talk to patients about is just genetically, you may be shift work's not for you, unfortunately, because it's always going to be hard if someone is finding it really challenging.
And we had a patient who used to initially own a car garage and then worked for a car recovery service he was called to attend a vehicle that was stranded, and he was himself found asleep in his own vehicle. So we had then to say, because every day shift was changing, so we had to say, okay, for next 3 months, you're going to do fixed shifts. Get your sleep cycle in tune, because at night he was using sedatives to go to sleep, and during the day or during his wakeful hours rather than day and night, trying to drink Coke and other things to keep him awake. And that just wasn't working. Or sometimes we look after a number of train drivers actually, particularly when they trigger any incidents. So before even they have accidents, if they have got a lot of things in their cabin which pick up their eyelid movements and eyeball movements and dozing and so on. So in those situations, we have actually used avoiding changing shifts for a period of time to get their shift cycle back, or a body clock back, and then decide whether this particular individual are they better off with sort of a fixed shift pattern. That is not feasible, particularly if somebody is self-employed or whatever. But we have to give, as David was saying and as Dr. Arora was saying, right advice to that individual. And sometimes it may be that the night shift or the rotating shift, which is the new thing these days. Because if you continuously move your shift, then what companies have found is that the downtime can be managed and you get more out of same workforce. But that's not how we are designed, and some people it's just not for them. So we have to be honest and write to their employer that that is not the right thing for that individual. We've got a couple of other good questions, David. So I think Dr. Mudit from Delhi is asking, could we use etizolam low doses along with melatonin to induce sleep in irregular sleep? And we also have a question from Dr. Tara, who says, will disabling blue light in mobile phones facilitate melatonin secretion?
Yeah, so I'll do the second one first. So yeah, that absolutely, reducing the blue light helps. So that's where turning down the intensity in phone screens, turning to the warm color temperatures, which is the night setting on a lot of the devices, can reduce that light exposure. Melatonin itself reduces the negative impact of light by around 50% for people too. So it has some sort of antidote to light effects in the evening. In terms of the first question, colleagues will need to help me about what that medication is, because it's not one I'm familiar with in Australia. Is it a benzodiazepine?
Yes.
Yeah. And so, yes, you can. So you can sort of brute force sleep using some sort of benzodiazepine or a Z drug like zolpidem, zopiclone, for example, in shift workers. But it's not a sustainable strategy. It is the type of thing maybe once or twice a week you might be able to predictably give them 4 hours of sleep just when you're totally exhausted to help recover or get you back on shifts. But once you're starting to do that, it's a pretty slippery slope, and it's telling you that, okay, this might work for a week, but what am I going to do next week? What am I going to do next month? What am I going to do next year when they're still doing the same thing?
David, do you use or do you ask patients, because these days there are plenty of sleep apps on mobile which really chart your sleep cycle and can give you detailed sort of information in terms of how regular your sleep or how good your sleep hygiene is, what sort of your bedtime wake up times are, and so on. Do you either yourself use it, or do you recommend it to your patients? And if you do, which apps would you recommend?
Yeah, so they come in a few different flavors. So I do like the wearables. as a data collection. So think of it as a multimodality data collection tool, be it a smartwatch or an activity tracker. But the challenge is often the same people who get insomnia are quite obsessive and tend to anxiety, and they can get too concerned about the data. I'm not getting enough deep sleep. I'm not getting too much light sleep. I'm waking too often. It feeds this whole obsession. So I want them to be a passive observer, just wear this thing, passively collect the data, and then you send the data to me and I'll run the maths on the data. It doesn't work like that. They're into the data and looking at it. So it is a bit of a double-edged sword in that regard. So yeah, there's those sort of apps, but I'm increasingly, now that there's the ability to use large language models and run analysis like sleep regularity index on this sort of data, I do like that. The other types of apps is for shift workers. There's a couple of CBT, so cognitive behaviour therapy for insomnia, programs specifically tailored for shift workers that are being delivered in a digital format. So there's one from Australia, from Monash University, that's just finishing up some research. So hopefully it'll be something that's available fairly soon as an app that's specifically tailored to shift work. And so there are some sort of app-based CBT programs or more intervention type programs.
So overall, do you think that the expansion, rapid and deep expansion of use of mobile devices and wearable devices, has that helped or hindered our sleep? And this is, and again, Dr. Gopal Kavita is asking, if we are to go back to our lives 10, I suspect they probably mean 20, 25 years ago without all these things, would that resolve a lot of sleep issues, or not necessarily? We are just now more aware of these. What's your take on that?
It's tricky. I think it's good and bad, because we see in clinical practice, we see the type I've described who become too anxious about it, but we also see them less in clinical practice, but they're more in the community. People who might have not been proactive about their health, but then when they start to measure their health with a wearable, start to then realise, okay, where I'm tracking is actually predicting poor long-term brain health, for example. So I'm going to take some active measures to improve my long-term brain health and sleep and other parameters. Now, we don't see them so much in clinical practice because they don't engage in the sort of specialist healthcare, because they're sort of more in a preventative space. But both exist in the community. So there's the good that those devices are doing, and then there's the bad as well, with that over anxiety about it.
I think we have already crossed 1 hour mark. So what have we? I think we have. So what we'll do is we'll take a final either a question or a comment, take-home message from Dr. Arora, one take-home message from Dr. Arora and one from Dr. Jhala, and then we'll sort of have one final comment from David. We don't want to disturb his sleep clock too much.
So I think I would conclude by saying that, first of all, thanks for bringing up this topic, because I think it's still a lot of it is people are not aware of it. They think of their sleep schedule as good and normal, and they think that waking up till late and working is fine. We can do with 2 hours, 3 hours, 4 hours of sleep, but it's taking a toll on their life. So I think we should bring it up more in our clinical discussions with all of our patients, and quality of sleep has to be discussed with all patients to at least make them aware of it. So, yeah.
Thank you. Dr. Jhala?
I would, all my patient or whoever, we have to fix our timings of meal and sleep. If we are fixing this 2 times, then most of the health issues we can address. So I would always say my patient, either you fix your meal dinner time or sleep time. So if you fix either of it, automatically the other will be adjusted. So and again, that is very important, because in India we have very less awareness about the circadian sleep disorder. So we are privileged to have this type of webinar to get more awareness even in medical profession also. So that is very important. Thank you so much.
One quick last question, David. Any long-term safety concerns with melatonin?
No,
Yeah.
not that we're concerned about. So, yeah, I'd like to thank the organisers. So thanks to SEAASM for having the webinar. I think it's a really great topic. And I'd like to just echo what was said about the meals and sleep, because really, there's very, very ancient teachings in the Indian literature about regularity of meals and a whole range of different things and its relationship with health. So there's a lot of wisdom there, and as we sort of modernise and westernise, we often lose that wisdom. Whereas in fact, there's a lot of value there. And just another thing we haven't talked about tonight is, think of sleep as a luxury good. To be able to sleep well, you need to be safe. You need to have a roof over your head, have a place that's got temperature control, that's sound controlled. And a lot of people don't have that luxury. And, we've sort of talked about the finer points of dosing and melatonin, but really for a lot of people that's, they don't even have the basic ingredients to be able to think about good sleep. And so we really have to think about some of those broader public health measures as well.
Perfect. Thank you, David. Thank you to panelists and all the audience members. Hope this was useful. Thank you to SEAASM again for putting this webinar together. Good night, David. Have good sleep, and have a good evening to audiences from India.
Thank you.
Take care.